Hello, and welcome to today's session, Understanding Trauma-Informed Practice and Engagement as part of the Equity, Diversity, and Inclusion Virtual Learning Exchange. I'm Carol Fancott, Director of Patient Engagement and Partnerships here at Healthcare Excellence Canada. If you have not yet done so, please do take a moment to respond to the poll question on your screen. Please scroll down to see and respond to the question and be sure to click submit to send your response to us. Now, before we begin, there are some tools to assist with the full participation of everyone who has joined the call today. We are pleased to offer this session with simultaneous interpretation into 3 languages. If you would like to hear the voice of our French verbal interpreter, please select French from the interpretation menu at the bottom of your screen. In addition, sign language interpretation is available in American Sign Language, as well as Langue des Signes Québécoise. Each of these can be accessed from the interpretation button on your Zoom menu. This session is intended to be a space for learning and reflection. Please note that there are supports available in French and English to debrief about the content discussed and to support our well-being. A counselor is available during the session and for 3 hours after this session at this number, 1-888-829-5815. This number has also been added to the chat, and you may contact them at any point during the session. If there is high demand for this service, you may be asked to leave a voicemail, and your call will be returned from a private number. You will also note that the chat box has been set to allow all participants to chat with our panelists, but not with each other. We assure you that your comments and thoughts are welcomed at any time throughout today's event, and our team is working behind the scenes to ensure key messages will be shared with the entire audience. With an incredible panel of speakers today, we have not reserved time to discuss your questions live today. However, your questions and your comments will be collated and responses will be shared after the event. And finally, please note that this session is being recorded and the recording will be made available via email and on HEC's website in the days following the session. So I have the privilege of co-hosting this session with Denise McQuaig, a Métis elder who has worked closely with us here at Healthcare Excellence Canada. And together, Denise and I co-chaired the advisory committee for this virtual learning exchange. Denise is currently board chair of First Peoples Wellness Circle and has been an Indigenous advisor on a number of boards and committees across the country, such as the Mental Health Commission of Canada and SANYA's Indigenous Cultural Safety Training Program. Previously, Denise was also the Director of Aboriginal Health for the Interior Health Authority in BC. I recognize that we are all gathering virtually today from various places across this country and beyond. I am joining you from my home office here on the traditional lands of the Mississaugas of the Credit, the Anishinaabeg, Haudenosaunee, and the Wendat people. At Healthcare Excellence Canada, we recognize that we are still learning how to respectfully support reconciliation efforts and to develop meaningful relationships and partnerships with First Nations, Inuit, and Métis governments, organizations, and communities. I offer this land acknowledgement as an act of reconciliation, and I reflect on the privilege that I have to live, work, and play in this city, now called Toronto, and I recognize the enduring presence of First Nations, Inuit, and Métis peoples across this country. Please take a moment now to reflect on the territory where you are joining us from. If you're unfamiliar with what territory you're on and the history that has been built and preceded it, we have provided the link to Native Land Digital in the chat. Now, before I hand it over to Denise, who will set the stage for today's session, I start with an offering of gratitude to all of you who are joining us today. The development of this series has been our invitation to you to learn together with us as we at Healthcare Excellence Canada are early in our learning in how to support equity-informed improvements across systems of care that address systemic and structural barriers. This is an ongoing journey as we learn, we reflect, and we unlearn. And while we know we won't always get things right, we are firmly committed to this learning as part of shaping a future where everyone in Canada has safe and high quality care. So we're heartened to know that we have many, many people with us on this learning journey across Canada and internationally from all sectors of care and health, with almost 3,000 registered participants on this call with us, all of us with a shared desire to learn together. And with that, I will hand it off to my co-host Denise to set us up for today's session.
Merci, Carol, and hello, everyone. I'm so pleased that you're all able to join us today. I wanted to take the opportunity to thank the advisory group that has contributed so much to the development of this learning series. For those not aware, this is actually the second part of our journey, the first part being the COIN model, and the looking at privilege and unconscious bias and the role it plays through all of the intersectionalities that exist within the realms of privilege. The advisory group is made up of individuals with both lived experience, individuals representing a number of pan-Canadian health organizations, and a number of provincial quality councils. They have been instrumental in helping Healthcare Excellence Canada think about the way in which we deliver learning through our webinar format. And so I'm really honored and pleased to say that the opportunity to provide counseling for those who may be emotionally engaged with this information, the ability to have a number of language interpretations, including sign language, has been thoughtful and a direct result of this advisory group's input. And we thank them so much for walking alongside us in this journey. If you haven't had an opportunity to be part of our learning in the first series, it is available on the Healthcare Excellence Canada website. And I would really encourage you to take the opportunity to review it and to consider how that intersectionality within the COIN model is also reflected in the way that we learn about trauma-informed care. I also wanted to recognize that one of my understandings about trauma-informed care is the understanding that we need to personally invest about learning of others and their lived experiences within our healthcare system, their personal lived experience and life journey that they've experienced prior to coming in front of us, seeking care and support for their well-being. And so at Healthcare Excellence Canada, we are going to be taking full advantage of February being Black History Month as an opportunity to build our learning, unlearning, and understanding of the lived experiences of the Black community across our country. I'd like to now take the opportunity to introduce you to our panel of speakers. We will be led and hosted by Carolyn Shimmin, who is a public and patient engagement lead at the George and Fay Yee Center for Healthcare Excellence. Carolyn's focus has been on patient engagement and lived experience research and intersectional analysis. Claire Snyman will be hosting our panelists today. Claire is a mother, wife, and patient experience expert who's also an author and speaker and has considerable energy in the advocacy for access to care and authentic partnership. Claire's lived experience is from the brain tumor community and has experience as a patient across 3 continents and multiple healthcare systems. Tammy White-Quill's Knife will be joining us via video today. She is a member of the Kainai Nation, part of the Blackfoot Confederacy in Treaty 7 and the southern area of Alberta. Tammy is trauma-informed, a survivor, and a believer that everything related to health and wellness is interconnected. We will appreciate Tammy's perspectives as a caregiver and advocate for Indigenous health across the continuum of care. Also joining our panel is Jake from Pickering, Ontario. Jake is a community leader, educator, counselor, and advocate who identifies and networks to help close the gaps of underserved communities, both in physical and mental health. Jake is a transgender person who is also a parent to a child experiencing our healthcare system as someone who lives with autism spectrum disorder, and is a child to aging parents who are also working to access healthcare. They bring a passion and understanding to this topic that we will all benefit from. And Sudhi Bar. Sudhi is a mother, wife, wellness, and small business coach, an expert in barriers to access to healthcare for minorities and women with lived experience. Sudhi was an individual who experienced a spontaneous coronary artery dissection and who is a heart and stroke survivor. She is also an expert in knowledge on navigating childhood trauma and complex post-traumatic stress disorder. We thank you, Sudhi, and all of our panelists for supporting us to learn and to grow. And I send it now over to you, Carolyn.
Thank you so much, Denise, for the introduction. And I really appreciate your words. I think how you define trauma was spot on. So my name is Carolyn. I'm located on Treaty 1 land, home of the Anishinaabe, Cree, Ojibwe Cree, Dakota, and Dene people, and homeland of the Red River Métis Nation. And also Winnipeg's water is sourced from Shoal Lake 40 First Nation. My belief is that trauma-informed practice is a matter of social justice. And I come here today not as an expert, but rather I'm here to support our brilliant panelists and moderator who will be sharing their incredible knowledge with you. I'm here to introduce a few different definitions and concepts and just give a little bit of an overview of trauma-informed practice. I always like to start off with this quote: let's face it, we're undone by each other, and if we're not, we're missing something. And it's a reminder that as human beings, we're complex, we simultaneously inhabit many social locations, and when we come together, we as individuals bring our own political, cultural, economic, subjective, and experiential knowledges to the table. And what this means is it can be messy, it can be uncomfortable, it can be complicated. And today's discussion isn't an easy one, but it's an important one when it comes to equity, diversity, and inclusion. And I'd like to remind everyone to be gentle with themselves and to practice self-care. Maybe the next slide. So what is trauma? Trauma is defined as one or more experiences that overwhelm an individual's capacity to cope. A traumatic experience can harm a person's sense of safety, sense of self, and ability to regulate emotions and navigate interpersonal relationships. Long after a traumatic event occurs, a person with trauma can feel shame, helplessness, powerlessness, and intense fear. So it's important for us to understand that trauma is widespread, it's a harmful and costly public health issue. Maybe the next slide. And evidence shows that patients with significant trauma histories, it can have an impact on their physical and mental health, their responsiveness to health interventions, and their ability to access appropriate healthcare services. And there also needs to be an understanding that healthcare systems that are intended to provide services and supports to individuals may themselves be trauma-inducing. For example, the use of coercive practices, such as seclusion or restraints in the behavioral health system, or the use of invasive procedures in the medical health system can be re-traumatizing to individuals who may have already experienced significant histories of trauma before entering the system. The next. So trauma-informed practice begins with building an awareness among healthcare professionals, decision makers, health researchers, patient engagement specialists, and public and patient partners, community members about the following: that trauma is a common experience, that the impact of trauma can be central to one's development, that there is a wide range of adaptations people make in order to cope with and survive trauma, and there is a relationship between trauma and substance use, as well as mental and physical health concerns. And there are different types of trauma. Trauma can be experienced early in life, including child abuse, neglect, witnessing violence, and disrupted attachment. And trauma can also occur later in life through experiences such as violence, accidents, natural disasters, war, sudden and unexpected loss, and other life events that are out of one's control. The intricacies cannot be overstated, and there are a variety of dimensions to trauma, including its magnitude, its complexity, its frequency, its duration, at what age trauma occurs, and whether it happens from an interpersonal or external source. There are 5 types of trauma. First of all, there's single incident trauma, and this is when an unexpected and overwhelming event occurs, such as an accident, a natural disaster, a single episode of abuse or assault, a sudden loss, or witnessing violence. In the healthcare system, sometimes we see examples of pregnancy loss or a sudden invasive procedure. There's complex or repetitive trauma, and this is when abuse is ongoing, such as domestic violence, war, or ongoing betrayal, and it often involves feeling trapped both emotionally and physically. Developmental trauma results from an exposure to early, ongoing, and repetitive trauma as infants, children, and youth, such as neglect, abandonment, physical, sexual, or emotional abuse or assault, witnessing violence or death, and/or coercion or betrayal. And these types of trauma often occur within a child's caregiving sphere and interfere with healthy attachment and development. Intergenerational trauma, this describes the psychological and emotional effects that can be experienced by people who live with trauma survivors. And what is often seen as coping and adaptation patterns developed in response to trauma, which can include alcohol and substance use, can be passed from one generation to the next. Now, oftentimes when we talk about trauma, we talk about it on the individual and interpersonal level, but it's also really, really important to talk about it at a collective level. And that's where we start talking about historical trauma. This is a cumulative emotional and psychological wounding over a lifetime and across generations, emanating from massive group trauma. These collective traumas are inflicted by oppressive and dominant systems of power like governments. And examples of historical trauma include genocide, colonialism, slavery, and war. And it includes forced displacement from home, discrimination based on race, ethnicity, religion, gender identity, gender expression, sexual orientation, ability, class. And in Canada, it's really important for trauma-informed engagement to include an examination on the role of colonization, both past and present, in violence against Indigenous peoples. And this includes consideration of the legacy of the residential schooling system, the 60s scoop, and the ongoing present-day colonial violence that is faced by Indigenous peoples within healthcare, education, justice, child welfare, housing, and government systems. And this leads us to what is called structural, systemic, or institutionalized trauma, which refers to the way that people are harmed by larger systems that many of us rely on, such as the educational system, the political system, the criminal justice system, and healthcare system. If you remember last year's talk with Stephanie Nixon around the coin model of privilege, these systems are set up to serve a small group of people, often at the expense of a larger group of people. And the people that are not served by and often harmed by these systems can be traumatized by these systems. So when we talk about systemic trauma, it refers to the emotional and psychological harm from inequities enforced through public policies and institutional practices such as discrimination in economic opportunity, employment, education, housing, healthcare. And unlike individual and interpersonal trauma that we talked at the beginning, that focus a lot on individual response, it really requires a collective response. Maybe the next slide. And so as you'll learn from our panelists today, we can't discuss equity, diversity, inclusion, and social justice without an understanding of trauma-informed practice. It's based on the belief in the strength and the resiliency of both individuals and communities, and the idea that recovering and healing is possible, that the answer is within individuals and communities. It's about taking the role of bearing witness to other people's sharing of traumatic experiences seriously, of upholding space for stories to be shared, and being fully present and actively listening. It's about sitting in non-judgment of the coping and adaptation skills that people may have developed in response to trauma and learned how to get their needs met at one point in time. It's moving away from what's wrong with you to have you had any life experiences that may have impacted your health and well-being. It's about responding to disclosures with strengths-based affirmations that recognize the courage it takes to talk about these things. It's about our role in continuously incorporating critical reflexive practice into our daily lives, constantly interrogating our own social location, the unearned advantages and disadvantages that may be associated with these, and larger systems of power and oppression. And because trauma involves feelings of powerlessness, it's about giving people choice, foregrounding collaboration, building trust and safety. It's about being able to listen to people's stories, identify the feeling they must have felt, and even if you've never had the same experience before, thinking about a time in which you may have felt a feeling of loss, of grief, of powerlessness, and understanding where someone is coming from and connecting from there. And it's also about being gentle with yourself and giving yourself the same compassion you offer to others. I'm so pleased to now hand things over to Claire and to our incredible panelists.
Thank you so much, Carolyn, for everything. And I'd like to welcome everybody to the panel today. I know this topic may seem daunting to some, and they may be hoping to have all the answers within this hour, which is a hard ask on such a very multi-layered topic. However, we do hope to start with this panel through listening and really learning from our panelists with very individual lived experiences, some of which may have occurred as a result of the systemic and the structural barriers and ways that really have been built into our society and into our systems. Thinking about how we might, at an individual level, increase our awareness of trauma-informed engagement and approaches to help these systems and society actually shift is a step forward. Systems cannot move on their own, nor can we actually remain in the status quo. As a patient partner and individual myself with lived experience of medical error, I bring my own trauma to my healthcare journey, and that continues to impact me, even as an individual with privilege. And that privilege, according to Stephanie Nixon in her coin model theory, which will actually be shared in the chat and the post-event materials, is one of being middle class, of being white, settler, and cisgender female. It's important for those engaging to first recognize their privilege and power, as well as the layers of systemic and structural oppression that Carolyn also alluded to that may be faced by many in order to actually practice that trauma-informed approach. So bearing all of these wonderful comments that Carolyn sort of prefaced this panel with, I'm actually going to start the panel. And firstly, I'd like to really thank our panelists, Jake, Sudi, and Tammy, for sharing their time today, for sharing their expertise and lived experiences with us. But first, we're going to start off with a video from Tammy White Quill's Knife, who is unfortunately not able to be with us today due to another commitment, but really wanted to impart her messages with this audience today. So thank you so much, Tammy, for offering up your time today to share with us your thoughts on this very, very important topic. So first, I'd really like to hear from you. What does a trauma-informed approach look like when you are receiving care?
Okay, Nistuakok Akstuaki. Translated, my traditional name is brave or courageous woman, or as my uncle say, resilient woman. I would like, before I answer your question, I would like to acknowledge my homeland, where I was born, raised, work, and live. The traditional territory of the Blackfoot, which consists of Kainai Blood Tribe, also known as Blood Tribe, Siksika, and South and North Bikini nations, and includes Tsuut'ina, Stoney Nakota's Chiniki, Wesley, and Bearspaw First Nations, and Métis Nation Region 3, all located under Treaty 7 in southern Alberta. In response to your question, Claire, when it comes to trauma-informed approach for those with lived experience as First Nation people, there is a lot to unpack. Colonization has really caused deep intergenerational harm. Also, racism and painful structural biases still exist today, so the harm is ongoing. It is important that everyone understand the real history of this country, especially those in healthcare. We need to unlearn our socialized assumptions about First Nations, Inuit, and Métis people. I can speak from my context, but each individual, family, and community context is unique, and so an individualized approach is needed. I have seen assumptions made about drug and alcohol use that have negatively impacted health outcomes. This is not trauma-informed care. We need to check our biases and racism at the door in order to stop the cycle of trauma. For many hospitals represent the institution similar to residential schools and Indian hospitals of the very recent past. Even entering the doors takes a lot of strength, and people deserve an empathetic approach. Please understand this. It's very important. Being treated like an object without explanation, not being heard or having a voice, and also the fear of perhaps not being able to leave are common and to be expected considering our past. Everyone deserves to really understand what is happening to them. Maybe this means taking the time to draw a diagram or have an interpreter, a basic human right for those who do not speak English as their first language. Please explain the why before every intervention, including physical touch. Eye contact might be minimal. This is not a sign of disrespect. Nodding might not mean the information is understood. Always check in on level of understanding or what is being absorbed. It is hard to understand when we are facing fear and mistrust. This may present in different ways. I could go on, but these are the key components. Understand our history and act with awareness and empathy always. This is why you chose a vocation in health, to help and not pass judgment.
Thank you, Tammy, for beginning to unpack such a complex area that you've been speaking about in such wisdom. I've been listening with very open ears. I'm interested to hear, when thinking about how you have been engaged in the healthcare system beyond your actual own care. For example, you might have worked with others on a research project, on an improvement initiative, or other health-related activities. What might that trauma approach look like to you? Or you might have examples of what trauma-informed approach might look like when working with others to make improvements in the healthcare system, in research and quality improvements and so forth. Maybe you'd like to share some of that information with us.
Much of what I have said just prior applies for research and engagement also. Consent is to be well informed. People must understand the historical context before engaging. Much of the harm caused in the past was under the name of research. So there is a lot of pain and mistrust there. People also need to understand that the First Nations principle of OCAP, which is ownership, control, access, and possession, are developed as a response to trauma also. This is about data gathered about First Nations peoples. Information gathered in our communities was and is rarely taken for the benefit of the community itself. And often we do not see action or even the results in order to have the data to advocate for ourselves. In many instances, the data collected was not always a true reflection of the community and often reported with negative results and henceforth the labeling. This is why even with engagement opportunities, such as storytelling or any sharing of information, I feel OCAP principles are very important. Oral communication has been a past and present way of sharing and transferring of knowledge for Indigenous people, and conducting narrative analysis of the accuracy of the interpretation and translations are equally important. I believe people have a right to know where and how this information will be used and should have the right to change their minds after further reflection. For research, there is a protocol also for each community when it comes to outreach and consent, and it's really important to understand this is your planning.
Tammy, thank you. I think you've really touched on some key areas there with regards trust, consent, and very much as well, thank you for bringing to light OCAP, which we can share in the chat as well as in the post-event materials, which I think is really important with understanding this area more. What I'd like to do to end off is to see if you have any more key advice that you would like to share with those listening today on what they can do as individuals, but also thinking a little bit more broadly at the health system level to help create that safe space for you and for others when collaborating in your care, but also across the healthcare system.
So my key advice is it doesn't hurt to learn about the history of this land and unlearn your biases in order to have a better understanding and ability to truly listen. Having a culturally sensitive environment recognizes that trauma is widespread and can be deep-rooted. And passing judgment or perception doesn't help with recovery. You choose the vocation in health, which is simply to help people get better or save lives. It's not to act as judge and jury. Any engagement or interaction should be done with respect, honesty, and transparency. That builds trust and the dignity for people to feel self-worth, honor, and respected. Simple. Treat individuals how you would like to be treated. Basically, until you have walked a mile in my moccasin, will you know who I am? To obtain consent, a person has to be well informed in all matters in order to make an informed decision of understanding. Understand that our information and experiences belong to us and need to be treated with respect and proper protocol. I think we need to look at how we've normalized a lot of these behaviors and make change. Thank you.
No, thank you, Tammy, and thank you for being so honest today, and thank you for sharing your wisdom, and most importantly, thank you for sharing your time.
Thank you for allowing me to sit on the panelists.
I'd like to welcome the other panelists, Sudi and Jake, back to their screens. And Tammy has given us some really important food for thought with her words and comments on really such a complex topic, and especially that referred to earlier by Carolyn as the role of trauma-informed engagement at a collective level. So I'd like to start off actually by asking you, Jake, what your thoughts are on what that trauma-informed approach might look like to you when you are receiving care.
Thank you. And thank you very much for having me today. I'm coming from the land of Mississaugas of Scugog Nation under the Williams Treaty. You know, I listened to Tammy, and I mean, she's so wise, and I take in what she had. So when I look at trauma-informed care, I keep trying to break down for folks that care for me that trauma doesn't mean like a trauma. When we think of trauma, even though Carolyn was really great about breaking it down, so many times our providers are looking at trauma like those very large incidents that happened or ongoing large incidents. And when we talk about our healthcare, we have trauma centers, right? It's not somebody walking in and saying, listen, I'm kind of really hurting inside here. You know, we're talking like massive things going on. So I'm always looking at like when I'm looking at trauma informed care for me is, you know, is my provider listening to me? Are they really asking like, what are my goals, right? And when we talk about that, oftentimes, you know, I can walk into a place and be like, oh, this is what's happening. They're like, great, let's talk about that. And, you know, and they either, I mean, I'm not saying prescribe, but they could prescribe or say, hey, do this or try this, or maybe you need some physical therapy, but they're not taking into account what are my goals? What do you want from this? So you're telling me that this is happening. Do you have anything that you want to gain from this? I think that the communication goes both ways, and they are knowledge holders, but so am I. I'm a knowledge holder of my own being, right? So, and I think recognizing in my particular situation, the erasure of my being within the system. And being able to help me navigate it or at least empathize with me, not sympathize, but empathize with me on that. And I guess really just holding the fact that if I come to them with something, it's my real trauma. For me, it's real and it's true, even if they're not quite sure they understand it. So that's what I look for when I'm getting trauma-informed care.
Thank you, Jake. I think I really appreciate you chatting about what it means to you at an individual level. And Sudi, I'd like to bring you into the conversation to ask about when you're receiving care and thinking to what Jake has said and what Tammy has said, what would that trauma-informed approach, what would it look like to you?
Thank you. For me, first, I'd like to acknowledge that I'm in Edmonton on Treaty 6 and Region 4 for the Métis. That being said, what Tammy said really resonated so deeply with me because it was authentic, wise, and encompassing of everything that trauma-informed care is to so many of us. For me, in my care journey, trauma-informed care means receiving care that is communicated in a non-convoluted way and where medical technical language and jargon is simplified. I say this because a lot of times care providers live in this vocation of healthcare, and the language has become synonymous to how they communicate. But as a patient, sometimes that is not easy to digest. For that, I'd like to encourage from a trauma-informed lens that care providers have a big picture communication with the patient where they explain in a non-verbal way, where patient-friendly terminology is used to bridge the gap between the provider and the patient, such as myself, and also to acknowledge that English is not the first language. This is a country of many cultures and migration and immigration. Um, and the language is often a huge barrier in feeling that you're heard, that trauma is being addressed. Furthermore, I'd like to get a family involvement in what I'm receiving care, because I belong to a community, I belong to a family. I'm not a single individual that is solely responsible for my own care. My identity is linked to my historical context and to the people I belong to and the place I live. And I would like the care providers to see themselves in that care model in a way that they too see me as part of their community. I'd like to also acknowledge that colonization has harmed and fragmented the stability of humanity and has alienated us between being providers and patient receivers. And that is often where the trauma-informed care is essential in bridging that gap. Thank you. I'm happy to be a panelist today.
Thank you, Sudi. I think your words on communication actually really resonated with me personally, and also went back to what Tammy was saying about, I think she spoke about explaining the why before every interaction and how that really speaks to a trauma-informed approach when individuals are receiving care. So I think there's definitely some themes that I'm picking up here. Jake, heading back to you, you've talked about what a trauma-informed approach might look like when you're receiving care. Can you tell me, when thinking about how you've been engaged in the healthcare system beyond your care, for example, you might have worked with others on a research project or an improvement initiative. What does a trauma-informed approach look like to you in that setting?
Oh, thank you. Yeah. So, as a so I'm a healthcare provider under mental health. And so for me, I think hitting just on research first, I've always very mindful. I think whatever research I get involved in, or those purposes of wanting to be involved in research, is really understanding the long history of some of the harm that research has done, specifically on minority groups of all sorts. And that within itself, like Tammy says, it's trauma inducing. And that oftentimes participants don't really fully understand, where's this information going? What's going to happen with this information? Is the information you're asking me that's causing me to have emotions around trauma that I've had, is it going to be worth that in the end? Like, what's going to happen? So I think we have to be very mindful of research just for research sake. And so specifically for me, I was working as an example of, I think, trauma-informed care lens work. That's very important, is we were building a gender care team, or we're trying to build a gender care team in a space here in Ontario. And, as we were trying to build it, the systems, I would say the organization, they were on board, but what's happening is we weren't looking at the whole picture. We weren't looking at everything, and what we were doing is we were just processing it as a thing, and we weren't looking at, like, how can we offset any sort of trauma we might engage with a client if a staff isn't prepared to work with them, if our systems aren't prepared to work with them. Particularly in this system, they had a phone system that used only the legal name. And you could only switch between, and so people were getting phone calls with names that didn't match, and all that kind of thing. And so we can say, well, it's a system, but we have to look at how is it going to affect the overall care of those we want to care for. What are the policies that are already in place? What is the internal staff support? So when we're building trauma-informed care for patients, we also have to look at who's going to give that care and make sure they're cared for. And if we're missing that within the system, then we're going to not provide the care that we want to. And we just can't look at let's offer this healthcare space, but without looking at what the potential trauma is that we could re-engage people in by not looking further down the row and addressing that before providing care.
Yeah, thank you, Jake. I think that, as you were saying early on, I think that full participation, especially in research, and actually Tammy also alluded to that as well, is so important. So thank you for bringing that up. Sudi, I'm interested to hear from your perspective what you might add when you've been engaged beyond your care, what that trauma-informed approach might look like to you, what your thoughts are in that area.
Oh, thank you so much for that question, Claire. When I think about what trauma-informed care would look like for in terms of design, I really think about what could we do to change the current systems and structures, as well as the layout in healthcare facilities, so that we could keep it in the forefront of the minds of care providers. And in that, I would like to share a couple of things that I would do in terms of that I believe would really link back to in terms of as health systems, research, and quality improvement. And one is a quote from Tanya Tikachoksky, which says, the unintended participants, any environment intended for an imagined population will surely show its intentions when the unintended show up. And I say this because a lot of times we must first acknowledge our inherent unconscious biases, subconscious realities that we are all, although might not be the same, have certain privileges in general. And when we ask ourselves these questions of, did I intend the unintended to be served with dignity and with respect, that brings it back to the forefront. Another one that sits really deeply in me is Martha Feynman's vulnerability theory, which states that when vulnerability is understood as a universal constant, the task then becomes to explore the strategies by which we can mitigate this vulnerability. Therefore, human beings are not rendered more or less vulnerable because of their certain characteristics, various stages in our lives, but that we are inherently vulnerable by being humans. And that is why we have homes and things to protect us. And the healthcare system and healthcare providers should acknowledge they too are human, and that humanity is the core driver for why they got into the vocation. One more thing that I like to answer, I know I've taken a long time, is the epistemic erasure. Epistemic erasure is the knowledge of certain communities, such as peasants, incarcerated populations, indigenous people, colonized, racialized people. Their knowledge is peripheral because of geography, because of their disability and their inherent disposition. And their knowledge, I would say, should be safeguarded and acknowledged. When we address these things on a broad ideological stand, it helps to disseminate down to the understanding of everyday life, because putting together trauma-informed care will not happen until we really analyze the society that has been created and that has been fostered by colonization and neoliberal ideologies. Thank you.
Sudi, thank you for sharing those quotes. I was sitting here and pondering them a bit, and actually the one that you spoke about vulnerability, that really resonated with me, because understanding vulnerability, I think, is actually so important. And that, for me, linked back to Carolyn's starting slide, where she was speaking about how we're often undone by each other. So I think this is important for us to keep in mind as we're discussing this whole trauma-informed engagement, that as human beings, this is how we interact. Jake, as we wrapping this whole multi-tiered discussion, that I find as you think you're starting to understand something, there's something else that pops up, really is complex and has so many different areas that intersect with each other. Based on what we've heard throughout this presentation from the beginning when Carolyn was speaking, thinking through what Tammy has spoken about, what key advice might you share with those who are listening in today on what they might be able to do as individuals, but also thinking at the health system level to create a safe space for you and for others when collaborating in your care, but also across the healthcare system?
Yeah, thank you. Wow, we could take weeks on this subject. I think when I look at it, and I've heard what Tammy said and what Sudi has spoken about. One is we have to acknowledge history. Two, I think we have to be okay with being vulnerable as healthcare providers. That you don't know everything, and that's okay. You can go away, you can go learn, you can say to your patient in front of you, never come across that, but I'm willing to work with you to find out what you need, right? And really starting to understand that trauma-informed care is not because someone's arm is hanging off, it's because maybe their soul's broken and they need support. And, maybe because they come see you every week or they want to come see you every week, they aren't being a pain. What they're telling you is that they need you. And it's kind of like that space to understand what is their trauma, what's happening for them as a whole person, and trying to help them work through that, right? So I think those are really key for individual sort of spaces, and that everybody has, when you give them information, and if they choose not to use it, understanding, trying to figure out maybe why, but not from a judgment place, but from an understanding of maybe what's happening. Right? You may prescribe a medicine for them that they can't afford. So we have to understand, how do we work around that, right? So I think individually, systemically, I think that there's a great space in there that to reflect on if you are systematically making changes or doing things without service users. Now, I recognize that everybody is a service user, even within the systems, but the ones who are really receiving the care, if they are not in every board, like some sort of board meeting, any place that you're making changes and their voices aren't equal, then that trauma-informed care will be very hard to achieve, because you're not going to be hearing the voices. You're going to be coming from lenses of high education, more business structure hierarchies. And I think that if I could bring that forward, that anybody that's in here from system places, that they have to look at the systems through the lenses of those that they are set out to care for. And specifically within trauma-informed care, we have to be very mindful of how we're doing that. So I think there can be lots of change that can happen. I just think that we just really need to do it from that multi-level space. And it really has to come from the patients.
Jake, your words, their soul is broken, really cut deep for me. And I think that is a true resonance of sometimes working with a trauma-informed approach. It's not something that sometimes might be visible. It's actually sometimes that is often invisible. And thank you for sharing that. Sudi, I go back, when I think back to Tammy's wise words on her video, she speaks about the trauma is often widespread and can be deep rooted. So thinking about advice that you might share on what people can do to help create a safe space, ending off, what would your words be for that?
Thank you, Claire. I have three plus. One, that care providers and care as caregivers, that we first ask ourselves, as a human being, what is my moral duty? That is a question that we often forget to ask. We often forget. And another question is, how would I like to be treated and cared for? When you put yourself in the position of the receiver, as the patient, as the dependent in your life, how you must put yourself in a position where you ask yourself, how would I like to be treated and cared for? Also, how can I foster healing in my interactions? And what can I do to fill someone else's bucket? And I would like to encourage everyone to get this book. This is a book that I read from my child. I'm not sure if you could all see it very well, but I will read it for you. All day long, everyone in the world, in the whole wide world, walks around carrying an invisible bucket. That invisible bucket is dignity that we deserve, humanity we deserve, and compassion that we deserve. We all are responsible for filling each other's buckets as we interact with everyone in the world, not just from a healthcare system, but it's a universal human right. And that's what I would say. Thank you.
That's a beautiful way to end off. And Sudi, I have a feeling people will probably be asking for what that book is. So maybe you can share that. There we go. Share that so that people will know what book you're referring to. So thank you so much. I think this has been a great discussion and appreciate all Sudi and also Tammy in her absence. So I'd like to hand over to Denise to wrap up today's webinar.
Thank you, and Marcy, Claire, Carolyn, and panelists, Jake, Sudi, and Tammy. I don't know about all of you, but I have been taking copious notes. And I'd like to take a moment to thank Healthcare Excellence Canada for the commitments that I saw in the chat, that resources and recordings will be shared with all of us via email later after this event. I truly appreciate that commitment to my learning. We learned from Carolyn that trauma-informed practice and engagement is an act of social justice, and she suggested that it was a paramount and important conversation in equity, diversity, and inclusion. I took special note of her interpretation that trauma is not just about the individual's ability to cope as a result of their lived experience, but it's based on strength and resiliency and the idea that recovery is possible. As I listened to Tammy, I made a few notes, including her challenges to us about unlearning our socialized assumptions of First Nations, Métis, and Indigenous people. The encouragement for us to be reflective and check our biases, and to take the time to slow down and explain the why before our interactions as we provide care. But she said something else that I thought was particularly challenging, and it was that we should not act as judge and jury. It made me smile because judgment is such a part of being human beings. I can pretty confidently tell you that I don't anticipate that Mr. Moose is looking at the other moose and saying, oh man, would you look at those antlers? But as human beings, we judge all the time. I am equally guilty because I think that I use it to assess difference in others and to find my place in space, in any environment. And so Sudi's comment, I thought, spoke to that idea of judge and jury when she said human beings are not rendered vulnerable. And so I'm going to take that and sort of stop and think about, if I'm in an environment where I am potentially judging someone, am I at least doing that in a way that I am not rendering them vulnerable? I loved Jake's contributions about, am I being heard? The power of choice, and that the patient is a knowledge holder. Consistently, the panelists talked about research as potentially being a contributor to harm, and some really important principles about authenticity, being mindful of the role that research plays, not being too narrowly focused, and the suggestion that we think even about the physical environment that we are in and how it keeps these concepts at the forefront of our minds. As Sudi so beautifully shared the idea of filling our bucket, it made me reflect on the fact that, as Carolyn described the 5 types of trauma, I could personally see myself within all 5. and that those lived experiences of trauma were instrumental in influencing my choice to be a career path of healthcare in the first place. And so I will also like to give you some hope as a care provider that we haven't forgotten about you. As we've began this journey thinking about patient perspective in trauma-informed practice engagement, part 2 of our learning series will be looking at the perspective of trauma from the health human resource aspect. We acknowledge compassion fatigue, vicarious trauma, and the many experiences that COVID highlighted for us as being challenges in our own personal well-being and the way in which we deliver care and are supported by the systems that employ us to do so. And so with that, I will hand it to you, Carol, and thank each and every one of you for being here today. Marcy.
Thank you so much, Denise, for those beautiful closing reflections. And again, echoing my thanks to this remarkable panel for today's session and for all of your wisdom and for your insights in helping us to understand what it means to bring trauma-informed practices into our work. I would be remiss if I did not offer a massive thank you to the big crew behind the scenes from our learning systems team, our many producers and interpreters who make it seamless for us to have a positive webinar experience. So thank you. So we look forward to welcoming you back to our next session, which is on March 7th, where we will be hearing from Bev Pomeroy and Marika Sandrelli from Fraser Health in BC, who will speak about the implementation of trauma and resiliency informed practices that support both those providing and receiving care. And so in closing, we ask that you respond to the poll on your screen. Thank you again for spending time in your day with us, and we look forward to seeing you again next month. This concludes today's webinar.